Today we're talking about eyes with Gajan. Please take it away.
So, my name's Gajan. I'm an optometrist. I've also qualified as a dispensing optician, as a contact lens optician as well. I've recently done some further qualifications as an independent prescribing optometrist. So, my breadth of knowledge and experience goes back about 25 years now. This includes hospital clinics, pop-up clinics in the community, high street practice. I've done some work with students and training and development there as well. So quite varied in what I've done over the last 25 years, and going forward is just going to get more and more varied.
Cool. So I think today what we want to talk about is mostly eye development at a young age. But obviously we know that it starts quite really early, as soon as they're born.
Sure.
We kind of start with black and white vision and it develops. Can we talk a little bit about what's
With
going
pleasure.
on there? Or
Of course. So with children, they tend to be a lot more sensitive to sound initially, and that's what the stimuli that they'll be attracted to, because those are the sounds that they'll hear while they're still developing in the womb. And then with their visual development, it will start off with an awareness of that the light is on, first of all, that there is variations in tone, in color, in shape. And as time goes on, that just gets more and more refined, more and more refined.
so colours being introduced into their vision almost.
Yeah.
And how long of a period is
So
that?
this does take around 6 to 9 months
Okay.
for the color vision development to become a bit more confident and a bit more solidified within development. But one of the myths is that at birth, a child can only see black and white. They can actually tell the color red as well.
Okay.
And then these colors will slowly go into the deeper variety of colors and then just get more and more refined as they go on. And one of the reasons is because they don't need to. So a lot of the development that a child has just from birth and going onwards is based on what does the child need. Because as humans, our nurturing and care is done by the parents at that young, delicate size and age. So those things will come when they're needed. And it's more to do with, they're learning to digest, they're learning to take on food and their milk. They're learning to sort of not be surprised when they need to go toilet and these things. As parents, we've seen that as well. So, and it's also about what's familiar. So, a fairly fundamental thing with children is what startles them and they become relaxed about because they realize it doesn't pose any danger or threat to them. And these things they just get more and more confident and familiar with. So that will just go throughout their lifetime.
So the eyes are just being exposed to mostly light, and obviously colours start developing. And I don't even remember when my kids were born, but is there any testing done in that initial 9 months of any blindness or any lack of vision that they may have, or not yet at all?
So one of the things that are checked by a large number of sort of early years, at birth and pediatric kind of care, is just to have a very gross general look as can the child track where the sound is coming from visually. So they'll look to see, okay, so we're talking to the child from this side. Is the child trying to kind of make eye contact or trying to look towards where this is coming from? And if something is moving in a certain direction. I can't recall the exact stages and phases this will happen in, but another thing they'll look at the eyes is to see if within the eye, looking through the eye, can you see the retina? So it's something called a red reflex.
Okay.
So when you go to an optician's and they're examining your eyes, they will look through your pupil at the back of your eye to see what condition your retina is, which is the inner lining of the eye. Are the blood vessels formed normally? Does the optic nerve look healthy? But with a child, you can't get that much detail. They're not going to sit still long enough.
Of course.
But whether you're seeing the initial reflection of the retina, which will come on like a reddish orange color, tells you is everything within the eye transparent. Because if it's not, then the likelihood of a serious problem at that age is already quite high.
Yeah.
So if there's something blocking the vision, that means the vision cannot develop, and you may end up with sight loss already in the eye from birth. Whereas if it's intervened with, if that whatever's blocking the vision can be removed, probably surgically, then we're more likely to get a normal vision. It may need help developing, but you have a more higher chance of normal visual development from there on. So the trouble with this is that I don't think this is consistent, and quite often parents, and this is not really their fault, but
consistent in what way? Consistent in terms of scanning or
scanning. So, for example, I'm only going by what I remember. So I've got 2 children. One is 4, one is 3. And I do remember, because things happen so fast at that point, and you've been there yourself, obviously, is they do some checks just grossly of the eyes, just the very big fundamental checks. And that's done pretty much at birth, around that time, before you're discharged from the hospital. But once that's done, you're left on your own. So what I want to talk about more and focus a lot on is how the importance of children's eye care and how to approach that with children.
So once they're beyond that 9 month
Yeah,
period,
exactly.
or,
Exactly.
3, 4, I think.
Precisely. So once we're out of the initial visual development, there's still a lot that needs to be monitored and a lot that needs to be assessed and tracked for the child to make sure you've got lifelong healthy eyes and lifelong good vision. An element of that is genetics. So how much of this is down to genetics and can't really be helped? How much of it are environmental factors? And how do we track these changes over that time? So a question I'm very often asked is, when should I bring my child in for their first optician's eye exam? So there is no minimum age. A lot of clinicians will be confident to start eye examinations on a child from the age of about 5, but a child can have their eyes assessed at any age. I don't turn any child away of any age in the practice that I am in, simply because although you can't necessarily get responses from the child as to what letters they can see on the chart, or they may not be able to describe their symptoms, there's still a lot you can examine. And I think that's one of the things we want to focus on is what kind of things do we examine at what age and what are we looking for?
Yeah. So so let's just say they come in for their first appointment.
Sure.
So if we just roll back just one before we jump
course.
onto their
Yeah.
first actual appointment, whenever there is, what intervening at an early age in that, say, 6 to 9 month period, the initial development, can we intervene and fix certain or correct certain issues or are they still too young and you've got to let the infant progress a little bit more, where they're a bit more stable to kind of then start putting procedures in place? Or do you have to wait till 3, 4 and see what happens, like before we move on to the actual?
Sure. So it's the second part. So what will happen is it really depends on the severity of the problem. So if it's one where there is something has already happened, such as something is blocking the vision, etc., that will need to be dealt with there and then. If it is something that's more of a developmental thing, what often will happen is an ophthalmologist, which is a doctor of the eyes, or an optometrist, or combined, and sometimes alongside that is a role called an orthoptist. So an orthoptist is someone who specifically focuses on the eyes coordinating together and make sure that the muscles are working together. Often I've heard them being described as the physiotherapists of the eyes. So they do work on vision development, but it's also to do with coordination. And often, their clinics are very heavily centered on children because they're still developing, but often they'll deal with adults who may have had accidents and injuries, etc., where the eye muscle coordination has become weaker. You also have a role here for dispensing opticians. So the other person involved with this dispensing optician is someone who will help with a very specialized fitting of what glasses frames are needed for that child. Because children, for example, will have, the nose bridge will be a little bit less developed. They'll be a lot more active, so they may need extra support around the sides.
Yeah, I've seen them.
Specialized materials that are, not likely to irritate the skin.
They're almost like, some of them I've seen, they're almost like a soft rubber, so they don't actually hurt themselves with
exactly.
The glasses.
And also, they're familiar with how to manipulate the glasses in a way that the glasses stay comfortable. And it's a great role in order to keep your patients educated, because often when you go into an optician's, they're one of the first people you will meet.
So you're almost saying like, I mean, if we're talking about glasses being prescribed at that age, you're almost talking about like swimming goggles being put on them.
Yeah.
So while they're moving around, head development is moving. They're on there. Yeah.
And,
Okay. Cool.
and it works. You know, my son started wearing glasses at 6 months because he had a problem with his left eye was turning outwards in a slightly unnatural way. So the intervention initially, so he's a prime example of your question actually. So I noticed that when we were taking photographs of him, that his eyes weren't straight. And sometimes when he was about 6 months, you're talking to him, one eye was looking at me, one eye was looking on the side. So I then had him referred to an ophthalmology clinic. An ophthalmologist had a look. And depending on which direction the eye is turning, gives the clinicians an idea of what kind of intervention is required. So the fact that the eye was turning out, they needed to check to make sure that is anything blocking his vision. So it's quite an invasive examination. My wife didn't enjoy watching it being done because it's not a comfortable way of examining, but it's important. And what they'd found was that the vision in his left eye was so weak that the eye wasn't focusing on anything at all, whereas his right eye was doing everything. Now, had we not intervened with anything at that point, what ends up happening is the right eye develops normally and reaches its full capacity and potential, whereas the left eye would have just stayed underdeveloped, and therefore the other problem is your child may end up with worse depth perception, so their balance and the depth perception.
Yeah, I was going to ask. So if obviously if your eye is not looking straight, what impact does that have on your actual vision with both eyes looking? So you're saying it's going to be impaired.
Depth perception. It can also limit you in certain careers. So certain jobs require a certain level of visual perception, being balanced between two eyes. It doesn't have to be perfect in both eyes, but it can limit you career-wise, and also a person's self-confidence. When we talk to people as humans, one of the things we tend to focus on is eye contact.
Yeah, of course.
And if you're not able to make eye contact, and that can make shyness in children as well. And this depends on the child's personality. So some children and some adults they're not fussed about certain things about the physical appearance, and nor should they be. But as a society, unfortunately, you know, children can become attentive and aware of this. So there's a cosmetic element of having eyes being straight may make the patient feel a little bit more confident about themselves.
Yeah. Cool. Okay. So thank you. So if we move on to now, what we were going to talk on to is what indicators are you looking for when they come to their first one? I mean, my oldest one was 4, I think, when she had 4 or 5, when she had her first appointment. What are you looking for at that stage? What indicators are you looking for? Obviously, long sight, short sight, and what are we looking for?
So when we're examining a child, the first thing we lock in on is a very thorough family history of is the family history of any eye diseases, of any turns within the eye, lazy eyes, etc. Anyone that's got any serious health and developmental issues within the family is important to know. And then when we look at the child themselves, small things like, do they have any allergies? Because certain eye conditions tend to show up where there are other health conditions there as well. And so if a child has, so if you look at like the allergy triad of hay fever, asthma, eczema, these 3 conditions are what we call atopic conditions. And they're sort of kind of related to each other in many ways in terms of your
atopic. Sorry, are you talking about environmental issues?
No. So it can be there almost an allergy or your body's immune sensitivity to certain things. So, for example, if you look at hay fever, the way your body reacts to allergens such as pollen, etc. And these 3 particular conditions can be linked to certain eye conditions later on, such as keratoconus, which I know we're going to talk about today. So once you know a little bit more about the child's health and well-being, the child's birth history is very important to learn about. So were they full term? So if a child wasn't full term, the chance of there being visual development delay is higher. If you've got a child who, for example, forceps were used. Now, forceps are such a critical development in childbirth because where they, it can save the baby's life. The downside to it is that there's pressure being put onto very delicate parts of the skull, and the nerves and the muscles that dictate some of your eye muscle movements are just underneath that. So just a little bit too much pressure can cause damage to that nerve, can cause problems with that nerve and muscle. But on the way up, compared to potential fatality, I would rather have a wonky eye. Let's be realistic.
Yeah, yeah.
So those things could happen during childbirth. If a child required extra, if the baby required extra oxygen at birth, if the child was significantly underweight, and then whether they've met their general milestones from there on. If you're someone who takes a keen interest in pediatric care, one of the other things that you'll ask about is whether mum was healthy throughout the birth and throughout the pregnancy. Now, this can change from things like gestational diabetes and fairly common things that can happen to women during pregnancy and during childbirth, but sometimes it's to do with the lifestyle of the mum. So if, for example, there's been drug misuse during that time, you may want to consider something like fetal alcohol syndrome with drugs misuse and alcohol misuse and dependency during the pregnancy. And these are things that we do need to consider. So luckily, I've not really come across many parents who get upset or they don't find these questions too intrusive. They understand that there's a reason behind it. So that's the first things that we ask about. Then the other things that we ask about, so before we even assess the child, the conversations that we're having are, has the school mentioned anything, or if the child goes to nursery, has the nursery mentioned that the child's not paying attention, the child is losing concentration quickly, do they seem to be copying things properly? So for example, the teacher may write a number and the child may be struggling to just comprehend what that is. Now, at such a young age, is this to do with their academic development or is this to do with their visual development? The only way you'll know is to rule one of them out. So those are the initial questions that we'll ask. Has the parent noticed any turning in the eye? Does a child seem particularly clumsy? Are they perceiving things the way the parent expects them to? Because we don't expect the parent to be an expert.
Yeah, of course, of course.
So, if you're watching something and there's a tree, the child knows that's a tree, but they don't recognize it properly, these can be indicators. There are other things that parents may notice that, for example, they get really close to the TV to watch it.
Yeah.
Now,
but is that more of a habit of kids? Because
precisely.
So far, my kids are fine. They don't need even my oldest, but they love sitting so close. Yeah. And it's almost like a reminder daily to move back.
They want to be immersed in the program. They want to join their characters on
exactly.
TV.
Yeah.
So the vast majority of situations where a parent's mentioned that, it's more of a habit thing rather than a vision thing, but not always. And how do you know? Get the child examined.
Yeah.
Same thing with iPads and tablets, etc. Other brands of tablets are available. We're not being sponsored by anyone, so but if you'd like to, just get in touch. Our children really want to get up close to these tablets and devices, but again, this is more of a habit thing and a fascination thing rather than a visual problem.
Yeah.
But sometimes it is.
Yeah.
So that's one element, is a thorough patient history. Now, one of the myths about an eye test is, like, for example, if I said to you, as an adult, you've gone to an optician's, and I ask you, when does your eye test start? When would you say your eye test would start? In your mind, mentally, at what point has the appointment begun?
Probably when I've started reading the
So you sat in the chart and you're reading the letters.
Yeah.
For the clinician side of things, it's often when we call the patient from the waiting area. There's an intentional thing we do there, which is we are observing the person's responsiveness, the person's coordination, also, especially with children, like their shyness and confidence, because that gives us an idea of how this is going to go. So you can start preparing for things afterwards.
Okay.
If I've called the child it could be an adult, if I had to call them 3 times, I'm thinking, okay, they may have a hearing issue we need to talk about.
Yeah, of course.
You may notice something that, for example, if a child is particularly clingy to their parent, they're feeling shy about being there. Okay, we need to just build a quick rapport then, rather than waiting until you've come in the room. So, and also what you're observing in a subtle way is how the child's natural posture is. Are they turning their head in a way? Are their eyes moving in an irregular manner? So you're talking to them, but you are in a very subtle manner observing them right there and then. And also, I'm looking at the parents, I'm looking at any other siblings that are in the room, just to start building a picture. These are things that we will ask about in the test room, in your consultation room, but you're starting it from there. And some practices even go so far as when you're booking the appointment, we'll start asking some really in-depth questions about things just to make things a bit smoother on the day. So from the parents' perspective and the family perspective, it's okay to go in with a list of concerns. It's okay to go in with a list of observations. I would advocate that for even when you go to the GP, there's so much going on, there's so much to discuss. If you go in with things listed down, it helps you to organize and formulate your thoughts. And also, it means you're not going to, let's say you had something on your mind and you forgot to ask about, you've got it written down. Any decent clinician will never mind that. In fact, it helps us. Because then I'm having to it makes my life easier. So, yeah.
Okay, cool. So, moving on from that, literally a continuation of that,
Sure.
is we've seen kind of more and more issues. Well, one, is it better technology that's kind of picking up more of these issues that are arising, or is it is there some sort of environmental factor, social factors, obviously being on social media now, time you mentioned iPads, tablets, TVs. Is it those kind of things that are making us wear glasses at an early age, or is it something else? Like, what's going on there? Because I see more and more kids wearing glasses nowadays, and they don't even shake them off. Obviously, that's a different issue.
Sure.
The ability to shake off glasses when they go older, we can touch into. But the initial is technology scanning for more issues, or are we developing more issues because of our environment?
I think it's more of a technology thing. I think that we are getting better at finding conditions, diseases, and diagnosing things and managing these things, rather than new conditions flaring up. So I think where we talk about, you go down any high street, there's opticians' practices generally in abundance. You can get, if you're elderly and you need someone to come and visit you, there's a lot of practices that offer a home visiting service. Certain areas also offer a screening service at school as well. The problem with that is that it's a bit of a postcode lottery, and certain areas have it, certain areas don't. So some parents will say, I'll say to a parent, oh, your child's 12 or 13, you brought them for an eye test, when did you last had them in? And say, oh, they would have had it checked at school. Because this parent had it checked when they were at school, and they've just assumed that it would have been done for their child. But that facility is no longer available in that area. And the screening that happens at school is a very basic check.
Oh yeah, I mean, you got to see how many kids in a X amount of time. So yeah.
So it's not anywhere near the same depth. So one of the myths I just want to dispel is, please do not rely on that as an indicator of perfectly developed vision, perfectly healthy eyes. It will pick up the a lot of the urgent cases that need to be assessed. But just because your child's had a screening check done at school does not mean they need to go and see an optometrist and have their full workup done of their eyes. If for nothing else, just to reassure you that all is well and you've got a set of baseline measurements, because from baseline measurements is from where we can start assessing visual development. If you bring a child in at an older age, we've got less chance to intervene to correct things that could have been corrected under the age of 7 or 8, because up to 7 or 8 is what's called the plastic period, or the developmental period of a child's eyes. So at that point, there's certain interventions you can do, certain things of strengthening the eyes, straightening the eyes. You have a much more reliable indicator of doing that up until the age of 7 or 8 years old. Beyond that, we can't really do the same efficacy of helping. So the younger you bring a child in, the better. And then we were talking about how the way we detect these things through how we practice. So there was a phase during the 90s and 2000s where it became very fashionable to wear glasses. So people were going to opticians, and I've seen this change myself, and I'd say, oh, how come you're here for a checkup? And they'll say, oh, I just thought I'd want to get some really cool glasses, some face furniture, as people often refer to it as. So I thought, let me just get a checkup done in case I need a prescription in there or not. So it became a fashionable thing. If you go to look at runways and the fashion side of things, catwalks all around the world, often they are used as an accessory. There's the whole nerd fashion and geek fashion and things like that.
I mean, you see even on adverts these days, you see very few celebrities wearing glasses in general, but then there'll be an advert for a particular brand where they're sponsoring their glasses, and it's like, what's going on? I don't see you. Well, from what we see from celebrities, like in all the media, we never see them with glasses. But then a certain advert will come out to be like, yeah, look, these guys are wearing our glasses, and it's like, how much of that is true? And like you said, face furniture versus an actual health. You're trying to rectify a health issue. In
a peculiar way, it kind of doesn't matter. If the outcome is that by seeing a celebrity or someone that someone admires or etc. is inspired by, wearing glasses, and that makes a person think, you know what, I might want a frame like that, but I also just want to get my eyes checked. I don't really see the harm.
Yeah, I think the only pro is to kind of be more acceptance of someone wearing glasses. But I think we've gone beyond that. I think considering how many people wear glasses in today, I don't think we need celebrities still. I think it's more the brand itself as opposed to making glasses acceptable.
This is a cultural thing. So if you go to many parts of the world, glasses are still considered a disability.
Okay.
Yep, and I've seen this with my own eyes, and where if you wear glasses, or there's family history of glasses, etc., it's considered a problem. What that problem is, I don't know. But I've seen it. If I talk from a personal experience, so about 12 years ago, I was in India. I was for a wedding, and I was at that age where certain relatives would say to me, look, you're getting to that age now, do you want to maybe settle down, meet people and things? We know we've got a neighbor who's got a daughter, if you want to meet and have a chat. I said, okay, fine. So, and this happened about 3 or 4 times over the period of about 2 weeks. I felt like I was getting set up, but fine. So I remember one particular young lady that I got introduced to, and I felt like she was scowling at me the whole time. And I'm used to that because, that's fine. You don't have to like me. It's okay. And I kind of said to her, like, are you all right? Is something I'm saying upsetting you or something? And she goes, no, but I'm not wearing my glasses. And I said, why not? And she said, my mum and dad said not to because of how it might look, what you might think.
But were you wearing your glasses?
I actually can't. I probably was. But I can see reasonably well without my glasses. This girl definitely could not. So, but it was this stigma of wearing glasses. So, and we see this in a lot of people whose family origins aren't from the UK, and they move, and it's still a big stigma of wearing glasses because it's considered a disability or considered unnecessary. And this is one thing as clinicians we're fighting against.
Obviously we're talking about India here, specifically here, and obviously I think most people know there is obviously an issue between women and men, and obviously if a woman's wearing glasses, that's a big issue. But also it's almost like a parental concern where our kids are going to have issues. If there's certain physical disabilities of the woman, they're going to be passed on to the kids. Now that obviously is a big problem, and it still needs to be addressed. But I totally understand, and I never thought about it like that as well. That places like India are still having those issues.
Yep, and you see that and that thought process unfortunately travels here. So if I see a child who's got a significant vision defect and I say to the parent that, this child needs glasses, the child understands and appreciates because now the child can see because we've shown them, but we get some resistance from parents, and sometimes these are cultural barriers, which in one way, being from that culture, makes it easier to explain. But when certain people's beliefs are just locked in, one could argue that it's negligent parenting by not taking the clinical advice that you've come to seek and understanding that there may be implications later on that could have been intervened with. But as time goes on, this becomes less and less of a concern because, as you said, people are more aware, wearing glasses is a bit more normalized. And this is where, going back to the whole celebrity endorsement thing is that the more we normalize this, actually clinically it makes things easier. So often, there are certain people over the years have been quite iconic glasses wearers. So Elton John, for example, prime example, very iconic glasses wearer, now has his own range, which is being distributed by a national chain, and it builds up an interest in glasses. But the secondary thing that comes with that is more of an interest in eye health. Another big thing that's been a big change technology-wise is the whole thing about blue light. So this was on Dragon's Den. You'll see plenty of adverts for this on social media, and there are a lot of misconceptions about blue light. But also it's become like a public talking point. Now, with this, blue light's been around for a long time. There are certain things about blue light that are proven, and there's certain things about blue light that depends on the circumstance. So the best way I would describe it is the human body has a certain relationship with daylight. So daylight has a certain wavelength of light, and that makes us be a bit more awake and a bit more alert.
Yeah.
As that light wavelength gets taken away as towards the evening and night, we go into more of a relaxed mood and we go into sleep mode. That's just how our relationship is with daylight. This doesn't apply to everyone. So what would traditionally be called your early birds and your night owls.
Yeah.
So there are some people whose preference is to be more active and more productive in the evening. They may find that's because there's less things going on. It's just maybe how they're wired. So if we take people who are, for example, let's say they work as a trader and they're working with the Far East, and they're online doing emails and things, and they're communicating in real time with a colleague in Japan, for example. This person's sleep pattern is being disrupted already because they're working nights rather than daytime.
Yeah.
Then they may be using devices and things which are making the eyes and the brain think that this is now daytime. So there's almost like a confusion that is this daytime or nighttime, because my body's tired but my brain is being kept active. And one of the elements of this is the blue light that comes from the screen. So if you wear glasses or lenses that shield that particular wavelength of light out, what it can do for some patients is make the eyes feel a little bit more relaxed. It makes the brain feel a little bit more relaxed, and they feel less distressed.
So the blue light is more of an issue because you have an absence of daylight, and that's the source of the light that you're getting into your eyes. Is that what we're trying to get to? Or?
Kind of. It's an artificial representation of daylight. And then if the brain is trying to go into sleep and rest mode, and you're forcing it to stay active, this causes a certain kind of distress.
Yeah.
And this can play havoc with your sleep. It can, for some people, go as far as causing migraines. But it's not as linear as that. So it's not saying that by wearing blue light glasses, your migraines are going to stop. I would say it's worth trying, and if it helps, great, but it can't be prescribed for that purpose. And this is where some of the social media information and things, the messaging isn't going to be as in-depth as that. So I'm very hesitant to prescribe or recommend blue light blocking glasses, but I wouldn't say to someone who wants to try it, under the understanding is you can try it. If it works, great. If it doesn't work, don't be disappointed.
Yeah.
As opposed to me saying, this is what you need. This is going to solve all of your problems.
Yeah.
So it's.
I guess the eye is way more complicated. The individuality is obviously
Exactly.
understanding, obviously. Cool. So obviously we've kind of hit on a question in terms of whether it's technology kind of improving our ability to scan versus environmental factors. And obviously you came to the conclusion it's technology, or we have an ability to scan for more. So what about, so before we wrap that question up, it's what about now everyone being in front of iPads and tablets consistently now? Is that not having an impact on our eyes, and this is a question I wanted to ask a bit later on, but we can mix it into this one. It's like before, when books and reading newspapers and articles became mainstream, and we're talking about quite a long time ago, book was a bad thing. With kids will obviously get lost in books, and obviously reading was evil. I'm going quite far back in history. It'll be bad for your eyes having a book so close. Then obviously reading was a good thing. Everyone should be reading, become more literate. And now it's TV. Now obviously the books and TV are two different things. But is there any deterioration or the eye not quite developing as it should do because of a kid sitting in front of TVs and iPhones and iPads?
Fine. So if we just layer the elements to this is, so any task, if it's done without a break, is at least going to strain things. Any task, whether it be physical exercise, whether it's just sitting for long periods and not moving. Yeah, you're always like, even we're sat here, we're relaxed sitting, but actually we're still engaging certain muscles while we're doing it. So this is why the first important thing is having variety in the activity. So one of the best pieces of advice that ophthalmologists, optometrists across the world will advise is something called 20-20-20. Every 20 minutes, for 20 seconds, look 20 meters away. What this does is that it keeps the vision dynamic and it stops you from locking in on one target for too long. So it helps with fatigue. The second thing is that when we're using devices, because a lot of our work now, it's device-based or computer-based, is we blink less. So this means that there's a higher level of dry eyes because you're just not blinking as much. Someone on a computer screen and someone away from a screen, the person on the screen will blink roughly half as much.
Yeah, you know what? You're actually very true there, because I remember when my young one, we used to play music videos on the iPad. We introduced music to her. We didn't let her watch too much rubbish on the internet, but I think she was around 2 or 3 where we'd put the TV on and we'd have music playing so she can hear sounds, get used to just dancing around. And I remember once where she was so fixated on the TV, I was just watching her and I see tears come down. I was like, nope, this has got to go off now. She wouldn't even blink. And I was like, parents, I think, need to really focus when they have a TV on. Just keep an eye out for your kids, because that was quite scary. I was like, blink, 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 and I see a tear. I was like, nope, okay, turn it off. Let's get away.
And it's a thing. And then as adults, we are just as guilty of staring. And often when we're doing a consultation with an adult, you say, well, your eyes are dry because you stare so much. And they say, oh no, I do take a break from my screen. I say, yeah, but if you're taking a break from your work screen and going on your phone, your eyes aren't getting a break. Yeah. So it's not the same thing. So this is why 20-20-20 works really well, because it's practical. Way back when, I remember the advice used to be every hour take 5 minutes off the screen, but that's not that practical. And
so I think, so what you said there, 20-20-20, and you're absolutely right. Walking away from your laptop screen, and then you say, I need a bit of me time, and all you do is go straight to the couch and pull out your phone. You got your you time away from the mental kind of what you're doing, the mental task, to something where it doesn't require much mental, but it's the eyes, the effect on the eyes. So that break should be stepping away, step outside, step in the garden.
Or even at the least, try to look out the window, look at something far away, blink a little bit more, and then what you'll find is that the fatigue and the tiredness is less. Now, in terms of how that's related to visual development in children, when children go through, especially when they go to their pre-teen to being a teenager, there's quite a big endemic of short-sightedness. So short-sightedness is where the vision far away is worse than vision up close. So clinically we call this myopia. And what's happening is more and more, because of the higher use of devices and children being indoors more, having perhaps less fresh nutrition, these all are factors with a child's eyesight progressively becoming more and more short-sighted. Now, this is a big trend we are seeing and have been seeing for a number of years, and there are a lot of studies that will say this is linked to do with prolonged close work. So if you take, for example, the Far East, where academia and study is a lot more intense than it is, for example, in the UK or pretty much anywhere else in the world, you've got children doing really close work for a long period of time, and that then leads to more and more progressive short-sightedness. There's lots of factors with this. There's new studies being done regularly, so by the time we finish this conversation, someone's going to probably post
that's what I was just about to
so
say.
Always, yeah.
Yeah, I was about to say, yeah. So moving from something like a computer screen and thinking of the perception of, okay, you know what, let's read some books now.
Yeah.
You're still putting that strain. Yeah, you're doing the better option in terms of for the mind.
Yes.
But you're still putting the strain on the eyes. So I think that's a big misconception as well. Taking your kids away from the TV is a good thing, but then putting their head down straight in books and writing, like you're saying, you're still the eye strain.
The eye strain, but that's the other flip of it is that's what eyes are designed to do. Eyes are designed to do things, is to perceive things, to learn things, to educate. So, if we want our children to develop educationally and develop critical thinking and also their creative imagination, one of the big differences between watching things on YouTube and on your devices and videos, etc., compared to reading books is the imagination side of things. When they're reading books, they are imagining what these things will be, and they're developing sentence structure. They also pick up of how to speak from the way they read, because the words flow in a certain
I know, I've noticed
structure.
that, yeah.
So, for example, I wouldn't describe your t-shirt as, for example, you'd say a loose purple medium t-shirt, not if you change the order of those words, it kind of doesn't flow. And a lot of this we get from reading.
Yeah.
So, for example, you wouldn't say like a green big dinosaur, you'd say a big green dinosaur.
Yeah.
And these things come from reading. So I would never want to detract parents from encouraging the children to read.
Yeah. Well, we're talking more about the strain. You've gone from one type of strain to the next type of strain.
So what we would do is the advice we'd give is that when reading, the further you hold the object, the better. Make sure you've got good lighting on in the room. Ensure that you're taking regular breaks from it. That's it. Because really, I'd rather a child read and enjoy reading and develop their, the cognitive behaviors and everything that comes, the benefits of reading and the education. But it's not the activity that's the problem, is how you're doing that. So also, like with reading a book, for example, you don't want to end up with a bad posture.
Yeah.
So ensuring that we're observing these things, taking regular breaks, sharing it with time spent outdoors, having the UV light exposure, and having the vitamin D absorption as well, because vitamin D is so important to vision development as well.
Yeah.
It's that balance, rather than saying, no, you must do this and you must not do that. Rather than being prescriptive, it's being a bit more holistic and understanding these are the realistic things we want to achieve with our children's vision and health. So
So I mean, before we kind of move on to the next section, one of the things I had in my mind was so we're picking up these early issues like long-sightedness, short-sightedness. What age is the eye still developing? Is it like from obviously early age, we know that, but what age does it stop developing? In our teens, is it like fully, that's it, your eye's not going to develop anymore? And then on the top of that, if we intercept that development and you give glasses, are the glasses kind of not forcing our eyes to become more lazier? Because, for example, if I go to the gym, I'm building my muscles. If I stop, they're going to go smaller, not in use, and they're going to become more poorer. So isn't that the same thing with trying to fit in glasses at that age where the eyes are still development? Are we having that effect on the eyes, or should they still be working?
So your vision and visual changes are a lifetime thing. The structural changes and the focusing changes will continue to change throughout your lifetime.
Yeah.
Because the eye muscles element is only a small part. We have to remember that your eyes are a sensory organ. So the fundamental thing is to make us aware of what's going on around us and interpreting that information, and then using that information on how to coordinate everything else. So if you were to say, for example, you're training your leg muscles in the gym, those are things that you are instructing your leg to do something.
Yeah.
Whereas with your eyes, it's almost the opposite. You're absorbing information, so it's more of an inward thing rather than an outward thing, and like an incoming thing rather than outgoing. So that development changes throughout your life. So you'll go through certain phases where this changes are a little bit more rapid. So the most fastest changes tend to be between the ages of like 4 and 7. So that's why it's so critical to have the first eye test done at around 4.5. And then you'll go through another series of changes at about 40, 45, where your close vision will start to change. Your eye's ability to focus up close changes. The most sensible advice within that is to have your checkups done every 2 years, because that way you can track before you become symptomatic of what changes are happening with your eyes. Also gives you a chance to discuss things that you're obviously concerned about. Now, how these changes happen is, so in the younger period, is to do with the vision is still developing. So the sensory awareness is still developing and the balance between the two eyes is developing. So if, for example, you have a child who's got one underdeveloped vision, eye in one eye and the other eye is developed pretty normally, there's a lot of interventions that can be done by that age in order to balance the vision out. So one of the things is patching. So you can, under the care of obviously the specialist care, a patch put over the stronger eye to force the weaker eye to develop more.
Or you can get these glasses which are slightly tinted or misted on one side. Yeah,
Precisely.
I think I've seen those. Yeah.
So you have patching, you have so frosting, we would call it frosting. So the purpose of that is the same. You can give, it sounds odd, but you give intentionally the wrong prescription in the good eye and the correct prescription for the weaker eye. So the wrong eye, the developed eye doesn't need to do anything. It's the underdeveloped eye that's developing. In some parts of the world, they'll also use eye drops in order to help with the vision development. This isn't really something that's done in the UK, but the other methods are used. But all of this depends on early detection. So this is why it's so important to take your children to the opticians.
But what I'm trying to say is once you've done the detection and it's been made established, aren't the glasses then also, they're not helping the muscles get stronger? Because if you're not wearing glasses, your eyes are continuously trying to struggle, like I was saying, you put the eye patch on, that one eye is now going to struggle. So shouldn't that naturally happen as opposed to someone wearing glasses? I know that's a specific scenario which it forces the eye to work, which is a good thing. But then wearing glasses for short-sightedness or long-sightedness, you're not allowing the eyes to struggle and try to focus on things that are far away.
So there's two elements to this. The first is, let's go beyond the age of, let's say, 11, 12, right? So the plastic period out of that. So this is where we're talking about the reliance on glasses or not. So teenagers, adults, etc. So part of it is the person's own perception. Part of it is the reality of what's going on. So the two slightly overlapping things. So if you have someone who doesn't wear their glasses, their eyes aren't going to get worse by not wearing glasses. Equally, if someone does wear glasses, their eyes aren't going to magically get better. The natural fluctuations in visual development from teenage to adult are going to happen regardless of whether or not you intervene with glasses. So that's the first side. Then we talk about this reliance on glasses. So let's say, I'll go through a few different scenarios. So let's say you've got someone who day to day feels their eyesight is generally okay, but when they want to really focus on something, they want to wear their glasses. So they may feel, without glasses, I can see 9 out of 10. I put my glasses on, I see 10 out of 10. If I've been wearing these glasses all day and then I take them off at the end of the day, I feel like my vision's gone down to 8. Yeah? This is a thing. I wouldn't know what the word for it is, but it's a thing.
More to do with fatigue, right?
Yeah, this is the whole thing that their eyes have gotten used to. So without the glasses on in the morning, their eyes weren't getting the help from the glasses, so they were having to work a bit harder to achieve that 9 out of 10. Then they put the glasses on, their eyes are thinking, wow, this is really relaxing for me. I can see clearly. I don't have to work so hard. So when they take the glasses off, they feel like, hang on, this is worse than it was in the morning. I may as well have not put them on. So the balance of this situation is well, it depends on the task you're doing. If you're doing something where I want to see as clear as possible, and you can accept that once I take those glasses off, it's gonna feel, isn't actually worse. It's gonna feel worse than it was, and that doesn't bother you, fine. Whereas if you then take them off and you think, I can't see anything at all now, I need to put them on again. Yes, that has made you a bit more reliant on the glasses, but really, this is my view on it, so what? If with glasses you're seeing comfortably and without glasses it's not comfortable, wear the glasses.
Yeah.
It's like wearing trainers when you go running. That's the best analogy I can give for it. It's like wearing trainers when you go running. You can try running without them. You will make your feet work harder. You may not be able to run as long as hard.
I get what you're trying to say there, because obviously the difference between 9 out of 10 out of 10 out of 10 is a very small thing, and if you need to do that specific task where you need to see 10 and 10, 10 out of 10, fine, perfect. But I'm talking about where the eyes are still developing. You found an issue. Are glasses recommended and they should keep them, or should they say, look, you know what, because your eye's still developing, it could get better. Should we keep the glasses off so the eyes continue working and struggling, and let's see where they naturally get? And if they got to a point of where it's not getting any better, let's put the glasses on.
That's precisely what I do.
Yeah.
So this varies from practitioner to practitioner, but that approach is what I would do.
And before I can let you continue, I'm not trying to advocate that people not wear glasses, because as a parent, I'm going to be honest. Sure. I don't want my kids wearing glasses yet. So the last 2 appointments I went to were mixed.
Sure.
The first one was, we should try. We can see a little bit of variation now in her sight. It's slightly weaker. We should get her on glasses. And my opinion was, she's young. She's developing. My understanding.
Of course, yeah.
So I was like, maybe not. She's too young. Second appointment she went to, they said her eyes are healthy. That's the word they use. Sure. Obviously, words can be very, you got to choose how you interpret them. So they said her eyes were healthy, but they needed to put drops in her eyes to fully assess, because there was a bit of variation when she was doing the test. So we had to come back for the question. But leaving that, they said they were healthy. So in my head is, look, they're healthy. Do I want her to wear glasses? She's 6. She's still got a long development.
Okay, so when they say, we were talking earlier about the function of the eye. There are 2 elements. There's the focusing element, and then there is the structural and disease side. When we say the word healthy, and I'm glad you picked up on this, because this is actually a phrasing issue. So when we say healthy, what we mean is that there's no presence of disease. That's what we mean by healthy.
Yeah.
So when we mean by, in terms of the focusing element, that the focusing issue is nothing to do with a disease-based element, i.e. it's nothing to be alarmed about. It's simply to do with the vision side of things. The 2 things overlap, but when we're clinically analysing them, we kind of separate the 2. So when we're looking for the disease, we make sure, is the nerve developed? Is there any muscle weakness? Is there anything growing where there shouldn't be? Is there something missing structurally? That's what we mean by healthy. What we mean by healthy is the absence of disease, absence of pathology.
Got you. Yeah.
When we're talking about the vision side of things, what we're talking about is how sharp and how well and how comfortably do they see. So, for example, I'm short-sighted, I have astigmatism, I don't have a disease. Yeah, so health-wise, it's okay. I've not got cancer of the eye, but I do need help for functionality, and comfort is what the glasses are for. Now, the reason they suggested using the eye drops is actually very sensible. So when a child is performing an eye exam or just anything with their vision, there is an element of the child not controlling what they're doing with their vision. So they could be straining their eyes without even realizing it. The vision could be fluctuating as a result of this strain. And it's pretty hard to tell with kids, because they're going to say sometimes what they want to say. They might be hungry, they might be bored. So the eye drops eliminates doubt. So when you put the drops in and you get that reading, that is taking out any fluctuation or variation being caused by the child, and gives you a much more reliable indicator of how bad is the child's eyesight really, or actually is a kid just messing about. So sometimes you're doing an eye test and
I did get, because it was almost like my daughter was playing, like guessing which things she could see, what she could at the colors. She was having fun. She's a very outgoing kid.
Kids being kids,
yeah, exactly.
So this takes that element out where, like, for example, if you were, I'm just going to think of something on the fly here, but let's say you want to analyze how someone breathes. And I said to you, I'm going to talk to you and analyze how you become very self-conscious about it. You become very aware of it. You may start breathing in an unnatural way because you're now performing for someone.
Yeah.
But if I waited until you went to sleep and then analyze your breathing, you are not interfering with the result even accidentally.
Yeah, of course.
So this is why we do these eye drops with children, because it takes out the personal element out of the child and there's no interference. You get a much more real result. And there are times where before using the drops, I'm thinking, this kid needs glasses. You do the eye drops, I'm like, this kid's just messing about. It's fine. But you're not going to chastise the child or the parent, because I'd rather you come in, had it checked, and then you know the answer. The worst case scenarios in these are where parents think, oh, the kid's just messing about, then you don't need glasses. The kid's just messing about, but actually they did.
Yeah.
So it helps us to make a much more scientific judgment. So I would encourage, anytime your optician or your optometrist says to you, we want to do the examination using the eye drops, it's an absolute yes, and you should do it. And then we were speaking a bit about like wearing glasses, reliance on glasses, and the progression of eyesight. So one of the big technology changes we've had that in the UK is now becoming more and more prevalent as a management is managing the progression of short-sightedness, so myopia management. So what would happen is many years ago, for many years, if someone turns up for an eye test and they're short-sighted, you'd be told, okay, so this is your prescription, here's your glasses, see you again in a year. You come back in a year's time, those glasses helped at the time, but a year later your eyesight's worse. Okay, here's some stronger glasses, see you next year. So one of the reasons behind this is that the reason that an eye can become progressively short-sighted is because it's to do with the size of the eye. So the size of your eye dictates your prescription. So dictates your vision and therefore your prescription. So as the eye gets longer, so this is called the axial length, as the eye gets longer, the shape, like a camera, the shape is now longer, so the focusing is now more, so the prescription required is now more. As a child grows, the eye can grow at a faster rate than the rest of the body. This is the problem. So this is why they're becoming more and more short-sighted. Now, if you consider the human eye is fairly round, it's quite spherical, it's quite round, but the glasses lenses that we're doing, they're fairly flat. That doesn't match exactly. Okay? So what that means is that at this point here, where the tip of the eye and the glasses are closest, that's a shorter distance. Everywhere else, there's a slightly wider distance. This slightly tricks the eye into thinking, well, I still need to adjust my shape to match this, and the eye still grows. So this is not that the glasses have made the eyes worse. This is that the eye is still growing at the rate it would have grown anyway, and the glasses haven't helped that.
Yeah.
So the way the technology has changed is something called myopia management or myopia control, where the lenses are now being changed form, where the lenses have extra curves put in them to match the shape of the eye better, to discourage the eye from growing so much.
Okay.
So it restricts the eye growth, therefore limits the progression and the worsening of the short-sightedness. So if you go to an optician's practice where they don't offer this, you need to go to another optician's. Yeah, it's becoming very much the industry like if you'd asked 10 years ago, it wasn't commonly done enough. But now, really, optometrists should be keeping up to date with the knowledge. You can get contact lens fitted for this purpose. You can get contact lenses that you wear overnight that does this purpose, or you can get glasses. They don't stop the short-sightedness, they just slow it down. So this means, let's say, for example, a child's prescription is a -2, age 7. Without intervening with myopia control, this child might end up as -7.
Okay.
But using myopia control, it may only go as far as -5. Now, that's still quite short-sighted, but it's a lot better than a 7.
Yeah.
The more short-sighted you are, the more likely there is for disease. So we're talking about healthy and unhealthy. You're mentioning with your daughter. So if you have a child or even an adult who's very short-sighted, the risk of retinal detachment is higher. The risk of glaucoma is higher. The risk of certain retina diseases is higher. So we're trying to limit that. Other elements come into it where the higher your prescription, the thicker your lenses, so you tend to be paying more for thinning lenses. There's less of that. Also, the lower your prescription, the less reliant you feel on your glasses. So there's loads and loads of benefits to myopia control. It's definitely something optometrists should be discussing with every patient who is short-sighted at least. But if you don't recall it being discussed, ask your optometrist. My child's short-sighted. Are they a candidate for this? I don't call it a treatment because it doesn't treat the condition.
Yeah.
It's a management format. Sorry. Countries like Australia and New Zealand are way ahead of the curve with this. A lot of the great research is done there. If anyone wants to look this up, it's a thing called Myopia profile. Really, really good advice there and really independent advice for parents. So I would definitely look that up as a takeaway, just some neutral information about that.
Okay, so moving on. So we're going to move on to obviously older generation. So, for example, I had keratoconus. That's the correct way of saying it. I kept it in my mind before you annihilate me. So I've had this for 20 years. Now, obviously, that developed a lot later in my life. I can't remember. It's been a while now. So I think first detection was done when I was maybe 15, 16. I could be wrong, but around that time. Before that, my eyes were generally healthy. I wasn't wearing glasses. I wasn't wearing any contacts. What do we know about certain issues? It doesn't need to be keratoconus. It could be any condition. What do we know about conditions developing in adulthood and progressing, and why do those certain things happen? Again, are they external factors? Are they health? We talked about food and health and diabetes. Because obviously as we get older, we get diabetes. We know that because obviously our diets are. What's going on with the eye that these issues or the eye goes from being healthy then all of a sudden, or are they just not being picked up because of lack of technology isn't that good at the moment to detect really, really small things that could happen later on? What's going on later on in life?
Sure. So if we go through sort of conditions that are more like teenage kind of conditions and sort of more adult, if we try to separate it. So keratoconus is where the very front window of the eye is called the cornea becomes irregularly thin, and rather than being like a nice dome shape, becomes more cone shaped.
Yep.
And this can progressively distort the vision. Now, with early intervention, and this is, I hope this is the theme for today, is early assessment, early intervention is the answer. If you don't take anything else away, take that away. So as that progresses and changes shape, what can happen is that the vision starts to distort to the point where wearing glasses doesn't do enough for it. So you then can get fitted with specialized contact lenses.
Yeah, you get hard
Precisely.
scleral lenses.
Scleral lenses are one of them. So a scleral lens is a very large, solid contact lens that covers a lot of the eye, and then it helps to
push the shape
down precisely back into a slightly more normal shape. That's one
very
way.
uncomfortable, but you get used to it. Experience.
Experience. I mean, it's uncomfortable definitely initially.
Yeah, you get used to it.
But once you get used to it, you've just gotten used to it, right? Yeah. And then you don't go through that discomfort again.
I mean, I'll get onto my experiences with them because that's a first-hand experience, and I don't think it's more like hearsay, like what someone thinks of what you do. I've had it, and I can talk you some people through quickly of what I experienced because I've moved over to soft lenses.
Then go ahead. The stage is yours.
No. Let's just, because I want you to finish what you were talking about. Because obviously, like we said, just quickly, like we said, we get comfortable. But yeah, we do get comfortable, but there are other issues because there's loads of people. I've seen more and more people in the hospital, young kids that were going through the same process I did 10, 15 years ago. And obviously they're coming into it now and other people. So I just want to let them know what they were coming into. But I want to let you finish first.
Sure.
So I mean, keratoconus is one of these, but other issues as well. With, like I said, I'm more interested on early intervention is important.
Sure.
But for those people who develop these issues later on where they haven't been seen earlier on, so do we know what the cause of that is?
These are primarily genetic, so there would have often been a family history of this, and certain health conditions won't show up until a certain point in life. So if we say, for example, multiple sclerosis, very commonly this will start to show symptoms, etc., when someone's in their 30s. So this is where, unfortunately, just the way our genetics work, these diseases won't even manifest until a certain point in life. It may be to do with what hormones are triggered throughout our lifetime. It may be to do with what kind of things we do. So a person may not be aware there's a vision problem because they haven't been looking at many things, and then they start reading books and realize, hang on, I can't see. The big element with eye health and a really big takeaway is rubbing your eyes is one of the most dangerous things you can do, because even if you don't have a genetic problem, you can then start causing structural changes that you did not want. And this is where we were speaking earlier about where patients have, for example, hay fever and their eyes get itchy and all they want to do is keep rubbing their eyes. The problem is, by continuously rubbing their eye, they're thinning the surface, and therefore they thin the surface and the surface can change shape and they can develop keratoconus. And it's an avoidable thing, but unfortunately it's been triggered by eye rubbing. So if you see your child rubbing their eyes a lot,
But that's one of the causes, right?
it's one of the causes, but it's one of the reason I'm highlighting is because it's an avoidable cause. Yeah, it's an avoidable factor in the equation. So if you have children who are rubbing their eyes, stop them from rubbing your eyes. Number one, if their eyes are feeling itchy or sore, one of the very quick things everyone should have at home: have a cold pack. Put something cold from the fridge on the cold eye. It can be a drink or whatever, just something from the freezer even, but from the fridge is fine, because as soon as you cool it, people often will find that the itchiness feels a lot more comfortable. They don't want to rub their eyes as much. So that's another thing I would want parents to take away: is have a cold pack in the fridge. Eyes are itchy, put something cold, and that should give you at least some relief, just to limit any damage being caused by rubbing of the eyes. As someone gets older, the other factors that can be with the eye health are whether they smoke. So smoking is one of the worst things you can do for your eyes, primarily because one, it makes your eyes a lot drier and more irritable because of the atmosphere. Second thing is that the blood vessels in the eyes are very, very fine. So the ones within the eye, very, very fine, very, very fragile. If within your bloodstream you are introducing quite thick and toxic elements that are in cigarettes, and that becomes within your bloodstream, once it gets towards your eye, the blood flow within your eye is not as healthy. Therefore, what it can cause is earlier age-related wear and tear, which should not have been there until much, much later. So there's an eye condition called age-related macular degeneration, which is where it's a degenerative condition of a very delicate part of the eye that is responsible for your color vision, it's responsible for your central vision, and the blood vessels feeding that are very, very fragile. So if you're disrupting your blood flow by using toxins that are in cigarettes, for example, that will massively adversely affect that part of the eye, and this is not reversible. So smoking is one of the things we really, really should avoid. In terms of dietary, because of the nutrition that your eyes need, if we are eating a lot of processed foods, I was going to say processed sugary foods, not something else, then those elements as well, because it's not as good nutritionally, you're not getting the vitamins and the nutrients that your eye and the elements that your eyes really need. So junk food, unfortunately, is a contributing factor towards bad structural health. Not vision here necessarily, but more to do with the health of the eyes. You have other health conditions or systemic conditions such as diabetics, high blood pressure, low blood pressure, high cholesterol. With high cholesterol, for example, it can cause the plaque that gets built up within the blood flow. If there is a large enough plaque within the blood vessel, the blood can't flow through it, so the blood vessel can burst, or it can just basically die off, and that can unfortunately mean that you can end up with a chunk of your vision just missing. Related to high cholesterol. I hope none of your audience are finding this frightening, but it's the realism of what goes on. So this is why your systemic health is massively related to your eyes. For diabetes, for example, I know often, and also culturally, when we refer to diabetes, it's a sugar disease. in Punjabi and many other languages refer to as sugar. Yeah, as in, it's not even called diabetes; it's called or sugar. Now, yes, that's the overarching factor is the sugar, but the impact is, it makes your blood thicker, stickier, and flow less.
Yeah.
So the blood isn't reaching where it should do. So this is why your extremities can be affected. This is why, so your blood that goes to your hand, goes as it reaches your fingers, for example, that's an extremity. These can be affected. Your toes, your eyes are also an extremity. So the way the eye's structured is in the blood flow in and out. It's an extremity like your fingers. So the blood flow is limited, and therefore it can cause more diseases within the eye. So if you are a diabetic, you should also be having regular eye screening done as part of your diabetic care, because blood vessel changes, the eye is the only part of the body where you can see blood vessel changes without cutting into the body, because you've got transparent surfaces to work through. It's not the same as an eye test for glasses, but it's an important part of overlapping with that. Other things that can come up as older, glaucoma. This is another eye condition. So glaucoma is sadly what's referred to as the silent thief of vision. You won't know you've got glaucoma until it's already too late.
Yeah.
It's where the nerve between the eye and the brain starts to die away and starts to fray and starts to degrade, and slowly your peripheral vision becomes more and more narrow and can cause tunnel vision. It is as frightening as it sounds, but here is the thing. If it's checked early and it's caught early and diagnosed early and intervened early, the chance of sight loss is massively reduced. So that's
glaucoma. Is that something that happens a lot older in life? Yeah.
Generally speaking, affects 60 plus.
Okay.
Can happen younger, but generally speaking, 60 plus. The one that people are often frightened by is cataracts.
Yeah.
So
I think that's one of the most well-known ones as well, isn't it?
I'd say it's the most well-known one. It's the most common one that we would ever see, but it's the one you need to be the least worried about.
Yeah.
Because the treatment is very, very simple. It's very straightforward. It's the most common treatment done of any health condition, any surgical treatment of any health condition in the UK. So you can, and the treatment itself takes like 20 minutes. So of all the eye conditions there are to worry about, cataracts is something that people should not be worried about. It happens as you get older, easily intervened with surgery, very, very high success rate with surgery.
Do we know what the external factors of that would be?
So diabetics develop cataracts faster. People who are smokers, it develops faster. Certain medications can cause a cataract to develop faster as well. So steroid use, for example. So if a patient is, for example, has a propensity for quite severe asthma attacks, and then they put on steroids for long periods in high doses, that can cause a cataract to develop faster. But I would rather you have a cataract rather than have an asthma attack.
Yeah, of course.
So it's that balance of things. With Western medicine, a lot of focus comes to what are the side effects of it, but really it's what is the balance of things. And this is where, as people, as public, we should feel confident to have these conversations. That okay, if you're recommending something like a steroid, which does have the potential for a lot of serious side effects, why is it being prescribed to me? What is the alternative? And sometimes the alternative is death. So that's why it's being prescribed. You
know what? They should be like you. More doctors need to be like you, just straight up. Would you pick death or the pill?
and that's it. And the thing is, it's not even to make a mockery of the conversation.
Yeah, of course. Yeah.
I really appreciate that why a person is concerned about a side effect, because they don't want it, and that's okay. It's okay to not want a side effect and be knowledgeable of these things. And also,
I think that's a lot hasn't helped with social media as well. I know that's a whole new topic as well, social media, medicine and stuff. We touched on it briefly in another podcast, but it doesn't help when obviously the side effects of any medicine are now put on the forefront. And obviously that mostly comes from obviously the US, where the standards, or I wouldn't say the standards, there's a lot more allowed to pass through, whereas Europe has higher standards of things being used.
It's stricter.
Exactly, yeah. So I think that worry on social media, because now it's global, you can see stuff happening there and here. It doesn't help when it says check the ingredients, check the side effects. They didn't tell me this, they didn't tell me this. And now people who are not educated or not kind of too kind of looking into this stuff, that's what they're seeing now first front. Look at these side effects, I was never told.
Yeah.
Because it wasn't never an issue, kind of, yes, I mean, it's a concern, but versus the alternative, or we're trying to cure, you, like you said, you have to weigh it up.
And a lot of medical care is, I don't want to use the word progressive. It's like, it's evolving. So for example, you may present with certain symptoms for whatever condition you've presented with, and you'll speak to the clinician about it and say, okay, these are the symptoms I'm having, these are the tests that have been done. And the first thing that's often done is, well, let's just try the most likely diagnosis based on what we've found so far, and let's try treating that. And if that treatment works, that confirms the diagnosis. Now, often the thought process, well, no, I want to be tested for all the possibilities, and then when we are certain that that's what it is, that's the treatment I want. That's logical, but it's not cost effective.
Yeah.
So that's one of the reasons it's not done, is that, well, if the majority of people, it's normally this condition, which is this treatment, and they don't have a side effect, that's all that's gonna be done. It's not an ideal system, but that is the system. And there's other things that will factor that in terms of like national policy, international policy, etc. But that's generally the theme. You know, if you don't feel you can have a frank conversation with your doctor about your concerns within that time limit, then you need to, learning ways to advocate for yourself is really critical. One of the big disparities in healthcare, and in fact, I won't just say healthcare, but anything in life I'm finding generally, is the better you are at advocating for yourself, the higher the chances of good outcomes. So there was a study done quite recently about how people who have English as a second language have a higher delay for getting appointments than people who speak English as a first language. And is this discriminatory or not? Right? Now, that's a lot to do with how well someone advocates for themselves. Same with, you know, healthcare in pregnancy. You know, we hear of these and we read of these articles and studies where women from Black and Asian and ethnic minority groups are given a lower standard of neonatal and natal care compared to parents who are, and mothers who are ethnically white, ethnically British, Caucasian, etc., and the difference in healthcare provision delivery for the two. And the often thing that's pointed at is, well, no, it's just racism. It's just racism.
Yeah.
But it's a lot more layered than that. It's to do with how well can you communicate your problem and your concern and your desired outcome. Now, this doesn't excuse the discriminatory behavior, but the reality is the better outcome will come, the better you can articulate your concern. Now, there's probably someone screaming at their phone right now saying, no, that shouldn't matter. The clinician should give the same amount of care to every single person, no matter how, and they should take more time to ask more questions and dig deeper and be compassionate and things. But the tragedy is, clinics are so busy, and, you know, especially NHS clinics, they're so busy and there's so many things going on. There's a human nature element of it, which I think gets disregarded. So I don't want anyone to use what I'm saying in their lawsuit against any clinician that they're suing. But what I'm getting at is, it's really important to learn to advocate for yourself and understand that it's your health, it's your eyes, you are going to take responsibility for that at the end of the day. Where this, in a weird way, comes around to an earlier question, which was, why are certain conditions being picked up more, is also litigation. So There was a really important case within optometry about 10 years ago. A child went for an eye exam with a parent, and the parent had certain concerns about their child's eye health. Oh, a child's health and vision, because they were complaining of eye strain and things. The clinician in this particular scenario, one of the assistants took some photographs of the inside of the eyes, showed it to the optician. The optician had a look at the photos, deemed the photos to show that the eye health was okay. The problem is they were the wrong photographs. They were from either the same patient from a previous visit or a different patient on the same day, but there was some kind of mix-up. There were other elements of the actual consultation which were also being quite disputed between the parent and the clinician. The problem was that there was a condition that, had the correct photo been assessed, would have caught that there was some swelling in the eye.
Yeah.
Unfortunately, the child had a brain disorder which had manifested with swelling in the eye. So the swelling in the eye was an indicator of the brain problem. The boy died. Yep. I think he was 5 years old. The boy's name's Vincent. And this case sent a lot of shockwaves within the industry, because certain people and just through habit and human behavior were getting lax with certain things with technology. So it caused a massive tightening up of how we as clinicians assess data, making sure that any tests that have been delegated to an assistant are logged as this has been delegated to an assistant, training our assistants better, not relying so much on what an unqualified person tells us. As much as they're there to assist us, they're not clinically responsible the way we are. So just making sure that you've got your house in order, and also that make sure you're communicating in a way where there's no dispute left at the end that I said, you said. So this is why record keeping is so important.
And this is what you're going to. It takes time.
Yeah.
And that's the biggest thing, isn't it? It's time to spend on each patient.
Time, but that's the job. In that scenario, time wasn't the issue. It was.
I'm talking about time of expectation of the patient, for example. Most people come in and they want an answer straight away. They're not giving you time to digest the information, take it away. I mean, an eye isn't a simple organ, like you're saying. It's a very complicated thing.
I think granted in terms of more complex health conditions, but I think with that case, the problem was it was just all the fundamental stuff went wrong. And from that, what's happened is a lot of opticians and optometrists, they went forward to actually upskill in their knowledge, because we realized that actually I could have made that mistake. Yeah, it ended up becoming a manslaughter case. It went up to the High Court. Eventually, it ended up in an acquittal, but you can imagine this went on for a number of years. Very tragic for the family, and really the only thing that's come of it is upskilling. For those that realize actually I could have made that mistake.
Yeah.
And from the patient's perspective is, again, being confident, advocating, being consistent with having your checkups done, listening to and if you disagree with the advice that someone's told you, it's okay to say, I don't agree.
Yeah.
Because either that means you haven't understood the point they're making, or it may mean that, well, you disagree, but you're willing to accept the outcome of not following it. So sometimes I might say to a patient, look, I need you to do this and this because of this problem.
Are you trying to say that me challenging what you said almost kind of double checks what you're saying, but then also kind of reaffirm what you got, the diagnosis, the kind of thing?
Precisely. So if I'd said, let's go back 10 years. Let's say I suspect you've got keratoconus. Now, at the first stage is that until you've gone through all of the specific tests for it, it's just a suspicion. So I would say, I've done this assessment. I'm going to refer you to have this assessed because I'm suspecting this. And you might say to me, no, I feel fine, thanks. I just wanted new glasses, or I just needed a checkup done because my work said I need to have an up-to-date checkup done. I'm not concerned about that. At that point, there's no purpose in my ego saying, well, okay, live with it, I don't care. This is where understanding human behavior is so important. is to understand, okay, so have I explained everything I could? Do I need to give a bit more depth at this point to explain and show my findings and the diagrams and the scans? Say, look, this is what normal looks like. This is what yours looks like. Because, and let's say I've not seen you before, I've got no earlier reference point for you. I can say to you, okay, let's see you again in a year's time to see if this has progressed. But if in that year's time it has progressed, you've missed a year of management, right? Now, sometimes a clinician may feel experienced enough to say, no, I think there's a suspicion here, but I want to monitor this myself in 6 months, 1 year. And if they communicate that with the patient says, yep, no, that makes sense. Fine, we're happy. But you're as a clinician, what really you want is your patient to not leave with any further questions.
Yeah.
And sometimes it's a case of signposting. If I don't know what the answer is, I don't want you to go away thinking, well, I don't know what the answer is. That's it. No, I don't know what the answer is, but I can signpost you to this organization or reference or website or whatever. Say, look, this is where you can get that information. I can, refer you, or I can just give you the details written down. There you go. Take that away. Look it up. It's fine.
Yeah. So basically, communication is vital.
So important.
Communication and follow-ups. We just need to make sure we're doing that. And obviously, this comes back to, obviously, the question was issues arising later on, but the onus is also on us essentially to make sure. We can't wait 10, 20 years and expect in that time nothing's happened, and then expect the optician to tell you that this is what we found and be like, well, you didn't come in for the last 10 years. So essentially that's what we're trying to get to. Yes, there is.
And you don't want to beat the patient with a stick either, because they already feel bad that they've got a condition. They were, dealing with that. Patient already dealing with that news that they've got this health problem. And there's maybe other things going on, because if you consider, the older you are, the more negative activity happens around you. Well, that's not negative activity, probably not the right word. There's more things that go on that you have to be prepared to deal with. You are going to be dealing with death of loved ones more so as you get older. You're going to deal with more financial challenges as you get older. Technology changes, language changes. I was speaking to a trainee the day before yesterday, and she was just observing me with a patient, and a patient was there for vision assessment for driving. And I said to her, look, sometimes these conversations can get a bit spicy, because you may have to tell a patient that you're not safe to drive anymore, and they'll find that upsetting. And she said, when you say spicy, do you know what that means? And I'm like, well, yeah, it can get a bit like, it can become a bit, the temperature can go a bit up because people get a bit angry. She's like, no, spicy means like a bit sexual. And I'm like, and I was
that's probably more of an issue with the younger generation, or the teenagers.
But you can appreciate that. Like, I've just turned 40. You're in your mid-late 30s.
40s as well.
You 40? Oh, okay. Really?
Yeah.
How old are you?
40.
I thought you were the same. I thought you were the same age as Manny. That's why.
No.
Okay, fine.
Got a bit off topic there. Just revealed our ages.
Fine. So, and then the other one, this was a couple of years ago, is I had a trainee, and I was talking to him about, like, there's a patient who needed a bit more specialist management, and I was explaining to this trainee about what's going to happen, and he goes, okay, that's peak. And I'm like,
I've heard that as well.
And I'm like, I don't know what that word means. Now, in my mind, I'm like, okay, so you've got the peak of a mountain, which is at the top, and that's like high, so that's good. I was like, well, no, it's not peak. It's bad, because this is what's gonna happen. He goes, no, bro, it's no, fam, it's peak. And I'm like, what does peak mean? It means peak. And it's like, he didn't last very long. But
to be, I was going to say, if you was to say that around any older Indian generation, a thapad would have come out straight there.
But what happens is, you can see, like, so, that's 40 down to 20. You now can imagine what it's like for a 60-year-old, how language has evolved, where they may not necessarily understand the subtleties of these things, and they can't necessarily enjoy the things they did before, because it's evolved, and through no fault of their own, they've not kept up. Technology is the same thing.
Oh yeah, absolutely.
You get these elderly patients that are being told to book online. Bro, they they have a landline and that's it.
Yeah, yeah.
Why are you asking this person to book online? It's unrealistic.
Yeah,
It's not.
I think that's more the industry kind of forcing this on everybody. So I think that's that's not any, like you said, it's not any individual's fault, and it's not
Yeah.
even your fault behind the counter or
Yeah,
whoever it is. If that's the only option you have
Yeah.
is to book online, what can you do either?
Yeah.
It's one of those things we see at GPs a lot as well with the online appointments. You walk in, check yourself in. Most of the patients are looking for a face-to-face. That's how they've done it their whole life. The communication between people.
And where this becomes even more of a problem is, so during COVID, a lot of universities moved towards online teaching rather than in person. And online teaching was either pre-recorded lectures or live lectures where students were told, you don't have to have your camera on, it's okay. Because what would often happen is you'd get, say you've got a room of 50 students. Out of those 50, maybe 5 have an absolute authentic reason why they cannot have their camera on. There may be some sort of family drama going on. They may have like some genuine anxiety about being on a camera screen in front of people. What happens to the other 45? They think, well, if they're not doing it, I can't be bothered either. And the trouble is, it reduces the human interaction part of learning. So you're just observing, you're not interacting. Your alertness is definitely less because you're not being held accountable for your attention. So if I'm teaching in front of a room, or like a live room full of 30 students, for example, I am watching to see their responsiveness, because if I see a student isn't nodding along, I would ask, did you quite catch that? Sometimes I say, sorry, I didn't hear you. Yeah, or they might say, I didn't understand. I say, well, tell me. But at least as an educator, I can see and observe that, is this person following what I'm saying? Because if you haven't caught it, maybe someone else hasn't caught it either. So we move together collectively. The tragedy with online teaching is that that element is taken out, and then forward on from there, healthcare professionals, they are in-person activities. You're talking to a person, you're smiling, you're watching for facial expression, all of these body language things, you can't teach that online.
Yeah.
You can write a list and a bullet point list and answer a question in an exam. So it's a big thing where when I do sort of a lot of my online teaching, I have to sometimes beg to say, please have your camera on. And then that way, when you're, especially with the older generation, when you're serving the older generation as your patients, they generally are used to and they prefer human interaction and facial expression, eye contact. And these are skills that I feel are diminishing because of how technology is going forward.
Yeah. Cool. I mean, we were going to go move on to technology in a few minutes. So, I mean, if we want to continue with that, I mean,
Sure.
what technological advancements have you seen which kind of, I wouldn't say make your life easier, which would improve healthcare in general for the eyes? What have you seen being introduced or is being introduced? I know you kind of touched on myopia.
Myopia
With the
control,
technology, exactly. But have you got any other examples of conditions, well, or even like picking up conditions at a younger age? Anything being introduced that we should be aware of?
So one very common thing being used within a lot of practices is something called OCT scanning.
You know what? I actually had that yesterday. It was offered to me at a cost, and I was like, not yet. I'm okay for now.
Okay. So so if you look at how an eye exam was done, say 20 years ago, you'd have a handheld microscope called an ophthalmoscope. It has magnifying lenses within an inbuilt torch, and you look through the pupil, and you can see the retina, the inner lining of the eye. So you can do a two-dimensional image in bits of the eye, and perfectly good way of assessing the eye. In many clinics, that's still what we have to do. So if you're doing home visits, or if you're doing a pop-up clinic, something like that, or small children, that's what you would do. Then the technology went forward where there was a device called a slit lamp biomicroscope, which is what often you'll see in opticians' practice. It sits on a table, it comes up like this, has two eyepieces for the optician, and then they use an additional lens on the other side in their hand just to direct where they're looking. And this allows us to do a more 3D image, 3D perception of the eye. So because I'm now looking with both eyes to examine you rather than just the one eye, I'm getting a more three-dimensional image, and it gives us a wider scope of what we're looking at. So this was the next stage. After this came photography. So that you'd have a camera set up with a very small aperture, and it goes through the pupil, and you can take a photograph of the eye, so you can see a certain area of the eye.
And all these are looking at the back of your eye.
Precisely,
yeah, exactly.
because this is the whole disease. Generally, the more worrying diseases will show up there. Okay, not always, but generally. So you've got that element, and then what you would do is you would take the snapshot photograph with a camera, and also look with your microscope. So you're doing belts and braces. You're looking at everything as possible. But what that doesn't tell you is it shows you the superficial layer of the eye within the retina. It doesn't show you what's behind there. So then the technology developed into an OCT scan. So OCT is optical coherence tomography, which is similar to an ultrasound. It looks at the layers within the eye beyond what you can see beyond what a clinician can see normally.
Yeah.
And where that is really helpful is if there is a disease progressing, it will show up in the OCT scan before, up to 4 years before any other technique will show you that we'd normally have in practice. I mean, so it's really, really helpful with disease diagnosis. It also helps with avoiding misdiagnoses. So, for example, if a patient's presented with certain symptoms and I look at their eye with the normal microscopes we use, and something looks abnormal, I might not know whether, well, I don't know how deep this goes, therefore I don't know how serious it is. Then we do the OCT scan and it shows actually it's very superficial, therefore nothing to worry about. But before that, what I'd have to do is I have to refer the patient to a hospital clinic or like a secondary clinic, and there's obviously a wait, sometimes 3-4 months. Patient's worried in that time to, oh no, what's going on? They go there and tell, oh no, it's nothing. Yep. So it helps with avoid inaccurate referrals as well. So it's a really, really great technology change. That's been really good. There's other really amazing things that are happening in terms of dry eye management as well. So if you have a patient who's got really dry eyes and eye drops don't work, other therapies don't work, there are certain practices that would have a link where they use elements of that person's own blood to help, because the absorption will be better, to help with dry eye.
Okay.
So, these are things that technology-wise are quite interesting. Certain specialty contact lenses that are made of a layer which is just very moisturized, being placed onto the eye, and then that just disintegrates over time. But again, these things are just very biocompatible.
So that sits on your eye permanently, would you say? Or
for a while, and then it will just need to be replaced after a while.
But it will disintegrate in your eye, so you don't need to take anything out. Exactly. Is that what you're saying? Oh, okay.
So you have these kind of things that are just gradually coming forward. There's an element that I don't particularly get involved with, which are much more in-depth surgical things of implants and that kind of thing, which isn't really my bag.
Yeah, because I know there's a lot of technologies being introduced for blindness, where obviously you can send signals straight back. Is it back to the retina, I believe, to digitize signals back to that? Yeah. Okay. Cool.
So with technology, another really fascinating thing, and it's something that anyone can get involved in, is there's a website called Be My Eyes. Now, what Be My Eyes does is let's say you've got a person who's blind and they want to do an activity like go to the shop and get a can of beans. Now, one of the biggest difficulties with sight loss, it's not the sight loss that upsets the person, it's the loss of independence. So yes, obviously sight loss is very tragic and is very difficult to deal with, but for certain individuals, the loss of independence as a result of the sight loss is what upsets them. Yeah. So let's say they go to the shop and they want to get some beans, rather than just have to, because they may not be able to see where the assistant is, and they may be in a shop where someone may not realize this person's blind. Or they go to the kitchen, they want to make some soup, but they want to tell which can is soup, which can is, macaroni or whatever. So they phone this number, and it's a video call with a volunteer, and the person will say, okay, can you just tell me which of these cans is soup, which ones is macaroni? The one on your left. Okay, cool, thanks, bye. And it's just a simple little volunteer, and anyone can get involved with it. You don't have to be an optician to do it. Where you just, and you get a call, and there's really nice stories that people say, this person went, they were going to a wedding and the theme was red, so they were just picking out what red suits them better. So this person was just on the phone with them doing a video call like a friend, just saying, look, you know what, that one's more of a deep red, that one's more of a pinky red. The deep red matches the color tone for your wedding invitation. And things like that. So that's a really great technology that's come forward to take advantage of with like social,
of course,
social side. Other things where like there's technology that's been around for years that I think may be worthwhile renewing. So audiobooks. So audiobooks are such a now we're familiar with them because you know we're always on the move. So if I said to someone who's maybe 20, what are audiobooks for? Their first response, well, you know, if I'm on the train and I don't want to physically hold a book, I can just listen to it like a podcast. Some of you may be listening to this on an audio stream. But what they were originally for were people who were sight impaired.
Yeah.
So they would have that. So some technology has been around for years and it works well. Some of it is just going forward. Now we have using AI to describe to us our surroundings.
Yeah.
So I think this is what you were touching on, where we have if you've got someone who's sight impaired and they want to be aware of what's going on around them, a message may tell you, okay, so there are two men sat down on ivory colored chairs. One is wearing this shirt. They can visually describe what happens using AI. And it's not 100% reliable.
I think this is where we're looking at glasses now with built-in cameras and stuff like that. But I'm a bit wary of them, kind of GDPR, security rules. You're technically recording someone without their permissions, and that's obviously being backed up. Now, obviously, that's a whole new other conversation and stuff.
Yeah.
But I get what you're saying. These aids for specific requirements are absolutely using, and they have a need for them. But someone just recording for social media where they're going absolutely rubbish.
Yeah, I think it's because being called out for nonsense is becoming more. It's a big social change, where you know if someone's doing something that you don't really want to get too involved in, often people are just left to do it rather than calling them out. The problem is that let's say, for example, someone is recording something in public. Legally, they're allowed to. You may feel a bit intruded upon by that. But if you confront the person and then it escalates, was the escalation worth it? And these are the decisions that sometimes we just make where you think, you know what, I just want peace in my life. I don't need the aggravation. I'd rather just move away from it. You know, it's what was where back in the day where, I mean, it still happens now, where people playing music loud on their phones in public transport.
Yeah.
The kind of person that tends to do that tends to be the kind of person you can't have a civilized conversation with. So is it worth the battle?
Yeah.
That's it.
Yeah, I get what you're saying. Cool. Okay. So I think our last question is personal projects, what you're working on. I know you alluded to some of the teaching stuff you do, so we can either take it from there if there's something you want to tell us about teaching or...
It all really overlaps. So when I been a bit younger, I was really interested in teaching. But then I fell into more of a clinical kind of role. But what your calling is will always keep calling you. So once I qualified as an optometrist, I then got involved in tutoring and training the next generation of optometrists. So once you've graduated, you then do like a placement year. And some places, they offer a lot of support with this internally. Some trainees feel they need a little bit more support. Some of them just want mock exams just for their assessments that come up. So I tutor with that. I've been doing that for about 9 years. And because I've got quite a wide range of my own academic experiences within certain subspecialties, that way I can go into more depth with these guys. So that works really, really well, keeps me quite busy. I think in the last 9 years, we've looked after about 2,000 now qualified optometrists. So that's quite a rewarding thing. One of the side projects we do alongside that is our voluntary work that we get involved in.
I think you mentioned that as well earlier on. Yeah.
So one of the things that we do is we do an annual inter-university competition for optometry students. It's a bit of fun. It's a bit silly. Some of it is clinical. Some of it is scenario-based. Some of it is quizzes. And we bring all these universities together at different locations across the country, and we do inter-venue competition. So we did one in Bristol, one in Manchester at the same time, and then we did a grand final between them, and this raises a lot of money for a charity called Vision Care for Homeless People.
Okay.
So all the money raised this year raised about 10.5 grand, with like some big companies sponsor it and support it as well. Specsavers were a big sponsor of it this year. And in the past, other companies have gotten really, really heavily involved. So it's been really nice to have them there and support that. And what the charity does, Vision Care for Homeless People, is they will go to an area or a church or something where there's a large number of homeless people. They'll set up a clinic where you have like an eye testing facility. They will do eye examinations for these people. Then straight after that, they will order up some glasses. The glasses are then funded through the charity or through sponsoring companies and contributors, and they get given a pair of glasses. Now, for a lot of the people that are homeless or are struggling or at risk of homelessness, they're not being able to read means they may not be able to fill in job applications. Not being able to read means they may not be able to communicate with their family. Not being able to read means they'll not be able to fill in application forms for housing, etc. So they lose a lot more independence. They may find that they're walking around, they can't see clearly because their glasses got broken, or someone who's homeless is more likely to have their stuff stolen. There are people who think it's funny that a homeless person's asleep there. I'm just going to take his bag. Yeah. Homeless women are at much, much, much higher risk of sexual assault. So these are very, very, very vulnerable people within our society, and looking after their healthcare needs in the way that one's capacity allows I wish there was no need for it.
Yeah, of course.
Really and truly, I don't want to make it sound like it's a good thing that this facility is needed, because
There should be no need for it. Yeah, we should be. Yeah, we should be doing it anyway. Yeah.
But the charity is set up in order to look after them, and then as a result of that, one of the things I get involved in is once a month, once a month, either Ilford or Romford, I'll do one morning where we do a pop-up clinic at one of the homeless centres. We get whoever's there using the facility for advice, etc., will come along, do a checkup, hook them up with glasses, and you then sometimes bump into these people on the street, and often they'll recognize you, say hello, and it's that humanity side of things, which is really important. The further charity project that we do is there's a charity called you've heard of Doctors Without Borders?
No.
Okay, so Doctors Without Borders, the full name is it's like, I think it's a French origin name, so Médecins Sans Frontières, which is where doctors who will travel around the world offering healthcare all around the world where the facility isn't there. So often this is war-torn areas, places that have been, societies that have been displaced, and they'll go out there and do voluntary work within that capacity. So Light Without Borders is the ophthalmology and optometry element of this, where they'll do a pop-up clinic. So a good friend of mine and my business partner, Carmelo, he will, when the money that we raise from our business, which is Out of the Box Optics, a large contribution from that will go towards, he'll fly out there, do a pop-up clinic, and work with local charities, and literally just eye test, glasses, go. It's what we can do, so it's what we do. And it's something that is sustainable. So every few months we'll go out and do that. And so if there's anyone sort of listening in that wants to get involved with these kind of charity projects, just reach out.
That's the other thing I was going to say. If you've got any addresses, obviously, I don't expect your number to be out there, but if you've got websites or Instagram pages you want to, we'll put them in the description.
Of course,
But if you want to make them.
So Out of the Box Optics is the business that I'm director of, where we get involved with these projects, and then a lot of it is where if someone has a specific project they want to get involved in, we'll happily signpost you towards that person and that team in order to get involved, whether it's in the UK or abroad. There's a lot of work to be done. There's a lot of people out there willing to do it, and what we like to do is just put these together and get these
and some of the charities that you get involved with, how can we kind of find out more about the charities?
Light Without Borders is one of those. Vision Care for Homeless People is another one. Crisis is another fantastic one. Crisis help with doing homeless shelters. So sometimes we go and do a clinic within their shelters, where patients are already there. Christ is another fantastic one. There's so many out there. Who else can I give a shout out to? Don't be upset if I haven't given your charity a shout out. So these are just
we'll add them in the section below
sure.
afterwards. So it's not a problem.
And then some that even I think yourself and Manny have got involved with. Like Happy to Help, for example. They started off with supporting children at Great Ormond Street Hospital, helping with facilities and some of the equipment they're funding through the charity work, and they do. Like next month, they've organised a football tournament, which teams just enter and the money goes towards the charity. So, there's some really, really great stuff. And it's also, if I can talk a bit about using your skill set. So a friend of mine, his name's Nav. He spent some time. He was just doing some travel around the world to find himself, and then he spent some time in India, and he ended up just going past like an area where there was like a slum. And he got talking to one of the local women there, and she was washing clothes on the street, the traditional method where literally you beat it into the floor to clean clothes. And he said to her, he got talking to her, and I'm paraphrasing the story, but many hours of her day were spent washing clothes, which could and should have been spent on much more productive things. But when you're in poverty, you do what you have to do.
Yeah, of course, yeah.
So he went away, and he's an engineer by trade. So he developed a portable hand functioned washing machine. So it's like a barrel. So do you remember the I don't know if when you have building work done, the cement mixers? It's basically like a cement mixer where you can hand charge it and it washes your clothes for you. And it drastically reduces how much time it takes to wash clothes. So what he then did was got a team together, designed it, patented it. It's called the Washing Machine Project. And then he's taken a whole load of these devices out into very impoverished places all across the world, and he's just given them to the people that need it. And quite a sweet thing that I've seen on one of his blogs is where he's taken it to the lady who actually inspired the whole thing. Her name was Divya. So the washing machine model is called Divya. And he's took it there and he said, look, this has been inspired by you. And from hardship often comes that inspiration if someone is motivated to do something about it. We're just here talking about it.
Yeah, of course.
I hope that
the drive to go out of your way to do something for people, it shouldn't be underestimated. It should be applauded, to be fair, and obviously recognised, because it's not easy. I mean, a lot of people would put themselves in a position to say, I can help someone. Very unlikely they actually do. The drive to do it, it's amazing.
And you're always going to get detractors. You're always going to get people discouraging you, trying to talk you out of it. But really, one really fundamental phrase that always sticks with me is that service to others is the rent we pay for our time on earth. And it's the tragedy is it's not hard. It's just allocating the time, fixing the time to do something voluntarily. And it's not for any reward. The way I see it, we've already been given the reward. The blessings we have in our lives are already the reward. We are just paying it off. Not the other. If you do it because you're expecting to get something out of it, it's not going to work out well. Because the motivation isn't pure. But if your motivation is true and sincere, nothing bad is going to come out of it.
Yeah, of course. I mean, we obviously everyone needs to understand we're all on our own journeys. We're at different parts of our life. So if you're in a position where you can contribute, perfect. If you're not, get to that position if you can. It might take you longer. Absolutely fine. But I mean, you've got people, I mean, especially Nav in the position he can help. Absolutely fantastic. Great. And if you can even have him on the podcast, even better, because I'd love to know his story. Very few people go out their way, like you said, from here in a position where they don't need to help to then go out their way to help somebody like that. That's an amazing person to be talking to and getting his information out there. And with yours as well, you're teaching, getting information out, helping with charities, eye issues. We don't have enough of those people. I'm not going to be wrong. There are charities out there established before yours, but we need more of them and more people helping, especially raising the issues, especially with eye health, kids, early intervention. That's the point of this podcast. So we can't leave it to later on and expect miracles to happen. If we address it early, we can understand it. Now we understand more about eye health. Parents will understand early eye development. That was the whole point of this podcast. So no, look, listen, it's been amazing. And if I have you on there again with any future developments, any charities, listen, I would love to have you back on here and we can talk again. But Thank you for your time, Gajan.
Thank you.